him some questions? Of course. Please. No?
You will be forbidden by Dr. Chauhan. So I think Dr. Chauhan will, first his slide now. Dr. Chauhan, what will you? Thank you. Thank you, sir.
Very good.
Thank you, sir. Thank you.
So the last speaker of the session is Dr. Chauhan, sir, who really absolutely needs no introduction. Where I am concerned, I am his perennial student and he is being my senior registrar. So whenever he said, and he asked me to moderate, karega kya? Maine kaha, no questions asked, I have to. Because like we know in the medical hierarchy, whether you are 40 years old or 70 years old, the senior is always a senior, the junior is always a junior. So I continue to be a student and junior. He is my boss, always, as it is. And he, jokes apart, would be dwelling on the diabetic perspective of Azelnidipine. Over to Dr. Chauhan, sir.
Well, friends, I think after two wonderful talks, I just have to give the finishing touches to the talk. Let me remind all of my friends here sitting, hypertension is a very debatable topic. We still have no clear definition of hypertension. So you can understand how controversial the topic is. We started with JNC1, the target blood pressure 120/80. We started with JNC8, the target blood pressure nobody knows, 130/80, less than 18 years, more than 18 years to 50 years, 130/80, more than 50 to 60 years, 140/80. In diabetic population, the targets are stricter. In people with CKD, the targets are stricter. So we are dealing with a topic which is very, very controversial, very debatable, and we don't have clear-cut answers to many of the things on the table. To confound the issue is the problem of the rule of halves in hypertension. And what is the rule of halves? The rule of halves says that of all the hypertensives that we have in the population, only 50% of them ever get diagnosed. Only 50%. 50% of the guys don't even know they have hypertension. Of the guys who have the knowledge of hypertension, only 50% of them ever get treatment. The rest, 50% don't ever come for treatment. Blood pressure कोई बीमारी नहीं होती. वो तो मेरे बाबा जी को भी थी. उन 99 साल के होके गए. कोई प्रॉब्लम नहीं थी डॉक्टर साहब. 99 साल में भी उनको अपने पोतों का पड़पोतों का नाम पता था. Of those guys who get treatment, only 50% of them come for regular follow-ups. And of the guys who come for regular follow-ups, बड़े-बड़े बंदे, Dr. George Baptist came, I heard him pre-COVID, and he said the target should be 120/80. I hear about the guidelines, about so many, trials, guidelines 120/80. I mean, everyone has this target in mind, 120/80. But is this 120/80 really the target? No. We don't know. We still don't know. The answer is still to be found. And to confound the issue, we have multiple molecules which we are using for the treatment of hypertension. One of the most important molecules that we are using is the calcium channel blocker. And the stand-alone, the gold standard molecule that we have been using since 1991 is a molecule called amlodipine. Since 1985. And everything that now we compare is against this molecule, amlodipine. And therefore, my talk begins on this note. So there is a high prevalence of hypertension. We know that the rule of halves I have told you, with almost 1 in every 3 Indian adult affected. So you can understand that the prevalence of hypertension is nearly 25 to 30%. Everyone has a blood pressure. The 1 in 3 guys will have a blood pressure more than 130/80. And then we have problems of white coat hypertension. Then we want him to measure his blood pressure. In his home, 2018, European Society of Hypertension guidelines, only the home blood pressure should be, home blood pressure is must for diagnosing a patient as hypertension. I need only 15 minutes. I will clarify the issue. Please give your 15 minutes.
Very good.
Incidence of diabetes in the world, we know that diabetes incidence is increasing, and in India, if it is 10.5%, it is going to increase by 1% in by 2047. In India, diabetes and hypertension today account for 40 to 6% for all cases of CKD. Dr. Sanjeev Gulati is the most eminent physician in the town, and he would vouch for that if you have a case of CKD, so you will either have hypertension or diabetes as an incriminating factor, or probably both. Among the CKD group, 65% people had hypertension and 31.6% had diabetes mellitus. So that summarizes the problem for you. These two problems are extremely important. So we have people who have CKD, who have hypertension but no diabetes. We have people who have hypertension, who have diabetes coexistent, and who have hypertension. And is the treatment changing? Is there a molecule preference for any of these? For both hypertension and diabetes, we have some common factors, and these common factors are microvascular damage and arterial stiffness. And the common salt hypothesis, you would remember, obesity and insulin resistance. There is increased reactive oxygen species. There is elevated RAS stimulation, sympathetic nerve stimulation, leading to altered renal sodium handling, altered immune response, and elevated inflammation. Inflammation is the key to everything that happens on a vascular, a microvascular, or a macrovascular level, either in hypertension or diabetes. So please remember, this is the most important thing. And the common risk factors include the genes, the insulin resistance, the dyslipidemias, and the obesity. And I have already told you. And then diabetes and hypertension leads to atherosclerosis, endothelial dysfunction, vascular inflammation, vascular fibrosis, arterial remodeling, leading to microvascular and macrovascular complications. These three most important things, and the basis of which is inflammation. And there are common factors both in hypertension and diabetes which are responsible for this. Now, does diabetes change all-cause mortality or cardiovascular mortality in age-matched, sex-matched people? It does. Diabetes prepones your death for everything matched, all-cause mortality. It changes your cardiovascular mortality, everything matched. So diabetes or non-diabetes makes a lot of difference, and therefore it is important to discuss which molecule should be preferred if your patient has hypertension and diabetes both. So what are the guidelines? So the first guideline, Dr. Sanjeev Gulati sir has already elaborated, and this is a recommendation which carries class 1, a recommendation, a combination of RAS blocker with a calcium channel blocker or a diuretic is recommended as initial therapy, where it is a therapeutic strategy for treatment of hypertension in CKD. You have hypertension and you have CKD, and this is a class 1A recommendation. Which molecule to start with? Dr. Rana sir? Calcium channel blocker. Sir, and you can use a diuretic, but remember, if your eGFR is less than 30, then instead of thiazide or thiazide-like diuretic, you need to consider a loop diuretic. What is important is CCB. Okay, class 1A recommendation. Now, your CKD can be proteinuric and it can be non-proteinuric. And what are the guidelines? So, 2018 European Society of Cardiology, European Society of Hypertension guidelines are, you need to use a ACE inhibitor and you need to use a calcium channel blocker as first therapy. Combine them. Now, for a non-proteinuric CKD, however, you can use a dihydropyridine calcium channel blocker as a first-line therapy, either alone or in combination with an inhibitor. So, for a proteinuric and a non-proteinuric CKD, the guidelines change. What are our own guidelines? Desi guidelines, KDGO and RSSDI. RSSDI 2022 hypertension management. In hypertension, Dr. S. N. Gupta is a very active member of the RSSDI, Delhi RSSDI, he is a champion. Among the calcium channel blockers, novel molecules are recommended in combination with ARBs for better CV, renal protection in diabetic hypertensive patients. Okay, the novel molecules. What are the novel molecules? The novel molecules are the ones which are acting on other calcium channels, other apart from the L-type calcium channels. And what are those channels? The N channels and the T channels. Okay, very good. You are already very educated. Now the KDGO 2021, a DHP, dihydropyridine calcium channel blockers or an ARB, we use as the first line anti-hypertensive agent in adult kidney transplant patients. Dr. Sanjeev Gulati sir is is heading the center where they are doing a lot of transplants, and therefore you have to understand that this is a DHP CCB or an ARB is their first line anti-hypertensive agent. And let me compliment you, you are so decent, you are not making any error. You are going to give me another 10 minutes, I will finish it and I will carry the message completely clear to you. If you keep quiet like this, and I assure you of a very good dinner after that, believe me. So, let us come to the specific point of calcium channel blockers. What are the three classical indications of calcium channel blockers? Alright, I am not going to take a PG exam, I will summarize it for you. They are used for hypertension treatment, they are used for angina treatment, and they are used for arrhythmia treatment. Okay, Dr. Sanjeev Gulati would remember from LNJP emergency classical days, PSVT. What are we using? Verapamil. Okay. I saw angina treatment, Dr. Sanjeev Gulati would remember Dr. G.D. Gupta telling us, remember, you must use this. This is the best anti-anginal. And for anti-hypertensives, we were using since 85, ever since they arrived. Although they arrived in 1960s. But we became students in Maulana Azad in 1980s. And we were using a lot of calcium channel blockers at that time. So these are the three classical indications of using CCB, the hypertension, angina and arrhythmia. Right. About the history of CCBs, in 1963 saw the arrival of verapamil, isoptin, the age-old classical agent for PSVT. It was a marvel to see a patient of PSVT with a heart rate of 200. You give verapamil, you give isoptin injection, and Lalit would remember, he never did, and a house job in medicine I did, and it was like a miracle. You give isoptin and you never wake up your SR because it gets converted. And then in 1981 we saw nicardipine, in 87 amlodipine, the gold standard against which we compare everything, and in 2003 what we are discussing today, Azelnidipine. Okay? But let me tell you, Azelnidipine had to struggle, like all of us. Dr. Tulsi, all of us struggle in our practice. This molecule had to struggle a lot. Azelnidipine had to struggle a lot. And it is still trying to find a place in practice. But let me tell you, once I give you the proof, you will believe me that it is one of the best molecules that we should be using. Right? So, brings us to a very important question. What are the calcium channels that we should know? And so we have this L-type calcium channels, we have the N-type calcium channels, we have the P and the Q-type calcium channels, and the R-type and the T-type. Why we are talking about them? Because in various tissues of the body like skeletal muscle, smooth muscle, vascular muscle, glomerulus, cardiac muscle, we have different type of calcium channels. And when we are giving CCBs, the calcium channel blockers, they are having different effects. and we are achieving different outcomes when we block these channels. And this is the basis of understanding why we should prefer Azelnidipine over Amlodipine, and why should we prefer Azelnidipine over Azelnidipine. And I will explain it to you. If you will listen to me with the patience that you have been listening to me till now. Just 7 more minutes. Okay? So, and there are subtypes, and it is very important that you know this, that why you are using a particular molecule and why a particular molecule is better than a standard molecule or a gold standard molecule that we are comparing it with. And therefore, now we come to, I would say, the second most important slide of my presentation, this one. So we have the traditional calcium channel blockers, the nifedipine, right? And where does it act? On the L type. And then we have the newly discovered CCBs, the amlodipine. And where is it acting? It is again acting on the L type. And then we have maybe discovered in 1995 the Azelnidipine, and where is it acting? N type. And you remember that molecule? Not from IPCA, Allen block.
Yes.
It is acting on the L, and it is also acting on the N. I am not talking about the subtypes. It will lead to confusion. Just remember LN. It is acting on the N and it is on the N. And then I will tell you why Azelnidipine is better than the Azelnidipine. How come it is, if Azelnidipine is acting on 2 receptors which are mediating so many actions, then why Azelnidipine is better? And then we have the most recently discovered molecules, Azelnidipine, which is acting on the D type, right? So I have detailed to you the 4 classical molecules. And now we will come to the renoprotective effect of CCBs in diabetes and non-diabetes patients, my presentation. Okay, so you give me 6 minutes for my presentation? Yes, Dr. Tulsi has already started the watch and we have 6 minutes. Exactly, friends. And therefore, we have this slide here with a lot of trials which were done, and this is about the renal protective effect of the L-type calcium channel blockers, and therefore I would like to concentrate on this. Dr. Sen Gupta, you would also be required to concentrate on this. You are my teacher now, although you are my student at one point in time. I take pride, you are my student. So previous clinical trials including ALA and INSIGHT showed equivocal effects of L-type CCBs. What is a classical L-type CCB? Amlodipine. Okay? Amlodipine. And therefore, amlodipine and nifedipine on the progression of CKD compared with ACE inhibitors, equivocal effects, not impacting favorably the progress of CKD, although controlling blood pressure. You understand? I can give you a corollary. Empagliflozin and glimepiride both reduce sugar, but one is impacting cardiovascular outcomes, EMPA-REG outcomes, but another is not impacting outcomes. Same thing. In concert, these observations suggest that reduced or no protective effect of the action of L-type CCB in the progression of CKD. Remember, L for loser. Amlodipine and nifedipine, although are blocking the L-type calcium channel blockers, controlling blood pressure, but mind you, they are not impacting the progress of CKD. We need molecules which are impacting outcomes. Alright? Right. So that is why we need the novel CCBs. And what are the novel CCBs and what are they doing? So they have the advantage of causing less reflex tachycardia, less fetal edema, and better control of proteinuria in comparison to the L-type. Remember, the loser type CCBs. And they are dual blocker CCBs, either L or L or L or D. Okay. So now we come to the Kurukshetra. This is the Kurukshetra. Okay, the Mahabharata was played out in Kurukshetra. And this is the most important slide of the presentation. Right? So we have the L-type CCBs here. They are present in afferent arterioles, and these L-type the calcium channels are being blocked by the classical molecules nifedipine and amlodipine. What are they doing? They are causing afferent arteriolar dilatation. Okay? Now this afferent arteriolar dilatation will be resisted by the afferent arteriolar smooth muscle, and it will cause resistance to systemic hypertension. It is going to be an interplay between the systemic hypertension and the afferent arteriolar dilatation. And what we are worried about is the glomerular capillary pressure. That is our concern. We are not worried what is causing what. We want to reduce glomerular hypertension. Dr. Sanjeev Gulati, as a nephrologist, his primary aim is to reduce glomerular capillary hypertension. Now, what is happening with the L-type CCBs only? In non-diabetic patients, either there is no effect or there is an elevated glomerular capillary pressure. We want to reduce the glomerular capillary hypertension. We are exactly getting the other thing. Because what they are doing is, they will have, counter-regulatory effects here. But here we are not getting any advantage. Now in diabetics also, either there is equivocal effect or there is a glomerular capillary hypertension. So you have tried to block it with amlodipine and nifedipine. No, it's not favorable. What is the next choice? The next choice is a blocker which blocks L and N type. Now, so you have an LN blocker, and the N receptors are present both in afferent arterioles and in efferent arterioles. Okay? So you block both. Now, what is happening is that they cause afferent arterial dilatation in the afferent arteriole, and they cause efferent arterial dilatation in the efferent arteriole. Okay, so this is good. This is good as long as the patient is a non-diabetic, right? Because these are N receptors. N receptors are mediated by nerves. But suppose your patient is a diabetic. What will happen? This patient will gradually have neuropathy, and therefore these N-type receptors are taken out of play. So ultimately, when the N-type receptors are taken out of play, what are you left with? L. And what is L? Loser. Okay. So basically, what will happen here is that you will have the same effect that you will have the L-type. So you need to have a receptor which is independent of effect of diabetic neuropathy. And what is that receptor? That receptor is T, which is present both in afferent arteriole and in efferent arteriole. Therefore, if you were to use amlodipine, it will act only on the L-type receptors. If you were to use azelnidipine, it will act on the L and the N receptors, which is good enough for a non-diabetic patient. But if you have a diabetic patient, and my specific talk is on the diabetes perspective, then my calcium channel blockers will be a calcium channel blocker, a CCB, which is acting not only on the L type, but also on the T type, which is independent of systemic hypertension, which is independent of diabetes effect, and the N-type receptors get affected in diabetic neuropathy, the T-type receptors don't. Okay? If you have understood this, the purpose of my talk is over, but I will continue. Renal protective effects of different type of CCBs in different patient populations, 2 trials in mild CKD and in diabetes, and both indicating that proteinuria reducing effect is better with azelnidipine. Similarly, with mild CKD, Dr. Sanjeev Gulati, mild, moderate, severe, refer all your cases to him. and in diabetic, protein reducing effect is better with Azelnidipine. Only 3 more minutes and I'll finish. So, we have calcium channel blockers and their clinical safety. Azelnidipine is, now you have understood, it is acting on L type and T type. It has no action on N type. And which is the receptor which is getting affected because of neuropathy in diabetes? N type. Okay, so then we have a molecule which has got nothing to do with N type. Right? Good. So CCB's L and T type blocking activity consistently offer favorable action on the development of CKD. Coming to the specific question of Azelnidipine versus Amlodipine, a very sensitive issue because we've been using the molecule and the last 5 slides are only devoted to this. So this was a study both to Azelnidipine but not Amlodipine reduced urinary albumin excretion, most important surrogate marker of progression of CKD and also of CAD. And carotid atherosclerosis subjects with type 2 diabetes, blood pressure control with olmesartan and Azelnidipine in type 2 diabetes. So the objective was to evaluate the efficacy of Azelnidipine and Amlodipine on diabetic neuropathy, nephropathy and atherosclerosis. A small number of patients, 40 to 75 years old, whose blood pressure was not sufficiently controlled with olmesartan, Azelnidipine 16 mg equivalent to 5 mg of Amlodipine, 32-week study, and the endpoints were carotid IMT, change in blood pressure and heart rate. What are the results? Azelnidipine reduces sympathetic activity and improves only 1 minute baroreceptor sensitivity in diabetics. Similarly, IMT decreased very favorably with Azelnidipine as compared to Amlodipine, and the urinary albumin excretion also only affected by Azelnidipine as compared to Amlodipine. Another antioxidative effect, 2 effects only, Dr. Sen Gupta. One is the 8-OST and the liver type fatty acid binding protein. Both results showing that there is the addition of Azelnidipine in reducing albuminuria and oxidant stress in hypertensive diabetic patients with CKD. Then I am just coming to the summary because that is most important. Everything was the same, 8-OST and LFP. So hypertension, diabetes and CKD are independent risk factors for CVD. Together increase the risk of CVD, morbidity and mortality. Remember my friends, a patient of CKD is more likely to die because of a ACS, because of a heart attack, than because of a renal issue. Dr. Gulati would vouch for that. Worsening of kidney function is a consequence of elevated blood pressure and is evident by a direct relationship between risk of developing ESRD and blood pressure severity. Higher the albuminuria, higher the risk of progression of ESRD. Albuminuria is the bottom line for predicting the severity of CKD. Any molecule which decreases albuminuria decreases the risk of dying from CKD as well as from CAD. Guidelines suggest that CCB is in hypertensive patients with CKD and diabetes. So there is a great role. All guidelines agree. You have to give a CCB for any person with hypertension with CKD or diabetes hypertension with CKD. As compared to Amlodipine, Azelnidipine provides better renal protection. Azelnidipine reduces blood pressure, heart rate and albuminuria. So please remember, Amlodipine causes reflex tachycardia. Azelnidipine causes bradycardia. Okay? Remember this. Azelnidipine reduces heart rate and albuminuria, and Azelnidipine improves cardiac sympathetic nerve activity compared with cilnidipine in heart failure patient with essential hypertension. So in essential hypertension compared to cilnidipine, you must use Azelnidipine because it improves outcomes in heart failure. Thank you very much for your patient listening.
Thank you, sir. And then just join us out here on the desk. And can we have the lights on out here? Thank you so much for a very wonderful lecture. So, quickly summarizing, not both, but Dr. Sanjeev Gulati, Dr. Vivek Kumar and Dr. Chauhan have elaborated on the multiple benefits in various clinical scenarios related to cardiovascular disease, nephropathy and diabetes vis-a-vis azelnidipine. So, just to quickly set the ball rolling, Azelnidipine in India was basically introduced about 5-6 years ago, but somehow it has not really moved the way it has, till now. Despite all the putative and the purported benefits which have been, and it was promulgated as one of the best calcium channel blockers by none other than an authority like C. Venkata S. Ram, who was one of the prime speakers. I still remember 3 to 4 years ago, multiple CMEs, and he used to be the speaker nationwide, purporting the use of azelnidipine. But somehow it has not moved. I don't know whether that has been due to lack of science or lack of marketing, the COVID pandemic coming in between, or whatever. So, and also vis-a-vis other CCBs like lercanidipine, felodipine, nisodipine, lacidipine, efonidipine, and also the new kid on the block, benidipine. So, how do you place it and what would be your explanation? So, I would seek this explanation from both the speakers.
I think, that's a very interesting question. I think probably the timing of the introduction of the molecule, I think COVID took a toll on it. That was one thing. Marketing obviously plays a big role, let's be honest about it. In any, success of any molecule. But nevertheless, our job is to talk about the science part, and we just had an excellent discussion, a 360-degree review of this molecule. Whether you look at the cardioprotective effects, whether you look at the renoprotective effects, or whether you look at its superiority because it acts as Sushil beautifully brought out, that in diabetic neuropathy, just because it's bypassing the N, it's not acting at the N channels, it's acting at the T channels, it still retains its efficacy. So from the science point of view, I think there is very little doubt that it's an excellent molecule. The drawback is there that yes, it may not be as potent as azelnidipine, but going by the current guidelines, if you anyway would be using two molecules, I think nevertheless it retains its numero uno position along with the angiotensin receptor blockers.
I think very well articulated by Dr. Sanjeev Gulati. I can only say that if you remember Azelnidipine, molecule which was launched somewhere in 1995, and when it came, I had gone to a conference in Hyderabad in 2008. Even after, you can see after 13 years of its launching, they had a small stall in, I went to CSI, and they had a very small stall at the back, just at the back, and I asked them, why are you here at the back? He said, sir, बहुत ज़्यादा सेल नहीं होता है, और क्या करें sir, इतना अच्छा molecule है. That was in 2008. 2023, Azelnidipine. The stall was of Silacar. I didn't want to use the name. Silacar is a 500 CR plus product today. Marketing makes a lot of difference. You need to teach science, but along with the science, you need to market yourself. As Dr. Sanjeev Gulati said, I think, and Dr. Sengupta also said, we don't know. There is no issue with the science. The science is perfect behind the molecule. Probably we are lacking with the marketing. You have such a beautiful molecule. You have a calcium channel blocker across the agencies recommending CCBs in hypertension, CKD. I think it is the first choice molecule in hypertension and CKD. If I may mention, And if Dr. Viveka sir was here, hypertension, CKD and CAD, the first choice molecule is Azelnidipine and not Azelnidipine, because Azelnidipine still causes tachycardia. Right? So there is something to do, and I have no doubt in my mind that 10 years hence, when we are in 2033 conducting how many? Maybe 1523rd CME of PFI, I am alive, and Dr. Tulsi sir is still alive with his white beard, here, yes. And Dr. Amrita is still talking to him so vehemently and romantically as she does today. And we are all feeling jealous that Dr. She doesn't talk to us. No, what I'm saying is, what I'm saying is that I have no doubt that it can still be a 500 CR product. Please combine marketing with your science. Right? And ma'am, I love you as much as Dr. Tulsi.
Doctor, this is also true. What is the practical aspect we have come across? Fall in BP is not that much. What?
No. It is the other way around, sir. I'm sorry, Dr. Arya, sir. The fall in blood pressure, head-to-head comparison, sir, please, head-to-head comparison, 2.5 milligram equivalent to 8 milligram of Azelnidipine, 5 milligram is equivalent to 16 milligram. The fall in blood pressure is more with Azelnidipine. The fall in heart rate is better. There is no reflex tachycardia. And it is the only molecule which is impacting albuminuria much better than Azelnidipine does cause reduction in albuminuria, but not as much as Azelnidipine. Amlodipine does nothing. So that there is some misinformation that it is causing less this thing, what you said. So please understand this. Absolutely, there is no doubt
I was
about it.
talking of Azelnidipine only. This causes the rest of BP.
Sir, mic दे दीजिए.
माइक इधर पहले से है.
सर आप सवाल पूछना चाहते हैं?
Yes.
पूछिए. अभी देखते हैं माइक. सवाल पूछिए.
So I think